Welcome. This webinar is being recorded and will begin now. You're encouraged to submit questions via the Q&A throughout. We will be answering them live at the end. Here is our moderator, Dr. Ron Carney.
Welcome and good evening, everybody. We are so pleased that you can all join us this evening to our session this evening, where we're focusing on cancer rehabilitation, specifically head and neck cancer rehabilitation during this COVID-19 crisis and beyond. This evening we have something very special in store for you. We have a few of my peers in the rehabilitation world who are experts and who share diverse backgrounds. And we have planned really a roundtable conversation around how we are adjusting the care for our patients during this time, specific to head and neck cancer, specific to the coronavirus epidemic, and really what the future looks like as well. And so I'm excited to share this conversation with all of you. And we want to get to know some of our audience as well. But first I want to go on to next slide, please, to introduce our panel, our virtual panel, if you will. And I will start. I'm Ron Carney. I am a head and neck cancer surgeon. I serve as the division chief for oncologic surgery of the head and neck here in Houston, Texas, at the University of Texas, Houston, and at Memorial Hermann in the Texas Medical Center. And my research interest is really with my team of physicians and providers around the rehabilitation of head and neck cancer patients. I'm going to ask my two co-panelists to also introduce themselves. Dr. Stubblefield, tell us who you are and a little bit about yourself.
Yeah, hi there. Thanks, Ron. I appreciate it. Everybody, thank you so much for joining us. This is very excited to talk, and I'm really honored to be here. So I'm Dr. Michael Stubblefield. I'm the medical director for cancer rehabilitation at Kessler Institute in New Jersey. But I'm also the national medical director for the Revital Cancer Rehabilitation Program at Select Medical. So I'm a physiatrist, but I'm also boarded in internal medicine, electrodiagnostic medicine. And basically what I do for a living is restore cancer patients to the highest level of function and quality of life using all the tricks of the trade for a rehab doc. And I'll pass it to Tiffany, who's really the one who does the real work.
Hi, thank you so much everyone for joining and for having me tonight. My name is Tiffany Kendig. I am a physical therapist by training, and I am the Revital Cancer Rehabilitation Program Director at Kessler, also in New Jersey. I have a number of years of experience and a strong passion for cancer rehabilitation, so I'm excited to be here tonight to talk to you about that.
Excellent. Thank you both, Dr. Stubblefield and Tiffany. So we want to learn a little bit more about our audience, and I know it's only 4 minutes past the hour, so some folks will still be joining, but we're going to start with our first audience poll. The audience will have the opportunity here to tap on their screens and tell us who they are. Are you any of these options? And look and scroll down. There are many options below those first four. So go ahead and click who you are so we can learn more about you and go from there. We'll give you just a moment or two to do that. And the results are starting to filter in here on my screen. And so I'll share a little bit about who is with us this evening in the audience. We have a large audience this evening. I'm seeing at least, I'm seeing more than 100 folks have already joined this phone call in the audience, which we're very excited about. We have, in highest numbers, we have 75% of you, about 75% of you are lymphedema therapists. We have another 6% of you who are PIA M&R or physiatry physicians. And we have another about 15% of you are speech and language pathologists. We also have a few RNs. We have a few physician assistants or nurse practitioners. And we have also a few surgeons and radiation oncologists and the audience today. So we have a good representative group of the stakeholders among the providers for rehabilitation in the head and neck cancer arena, and we welcome you all. Thanks for coming. Let's go on to the next slide. So I'm going to pivot to you first, Michael. And I want you to take us through the timeline a little bit. You're in the capacity of not just providing cancer rehabilitation care, but you're also directing one of the largest, if not the largest, network of cancer rehabilitation facilities and providers across the country. So take us through the last 2 months and bring us up to date on how cancer rehabilitation is being performed at your centers.
Yeah, thanks, Ron. So yeah, in my capacity as a medical director for the Revital program, it's, several hundred therapists at several hundred facilities in, 14 or 16 states. It's actually hard to keep track of it. And our strategy really was to provide comprehensive cancer rehab services to patients who really didn't have access, right? I think everybody on the line here, I think, has a pretty good sense that if you're doing a really great job in your community, the community next door to you may not have those services. So we've been growing, expanding, doing really well, and then COVID hit right in the middle of one of our national team meetings. We quickly came back. We're a very resilient group. We like to say that we're building the airplane as we fly it. And our strategy was to build out a couple of things. Among those was the Telehealth, Telerehab program. And what made that possible really was a liberalization of the rules governing what we could do, what we could bill for. And that's still been very much something that's been evolving. Tiffany will come on and I hope talk a little bit about it too. She's been absolutely instrumental, and on the therapy side has been spearheading our initiatives here. But the basic idea was these patients could no longer, as you all know, safely come into a rehabilitation center. Cancer rehab, just like all rehab, is a very intimate undertaking. If you have a patient with neuropathy, your hands are wrapped around them, often when you're working with them on gait training and that sort of thing. And we quickly tried, and successfully, to create services that include not only physical therapy, but also occupational therapy, lymphedema therapy, which I'm sure we'll have the opportunity to talk about, speech language pathology, cognitive, and of course, from my end, physiatry services for the medical sort of quarterbacking of this. I have been seeing patients virtually for the last several weeks for the most part, except for patients who need injections, who have chronic pain issues and acute pain issues that have to come in. Otherwise, it's actually been going shockingly well. There's certainly some drawbacks to it, but we've been doing, I think, a reasonably good job of keeping the patient safe and getting good outcomes rehabilitation-wise.
Thank you, Michael. Tiffany, tell us more a little bit about what has worked and what hasn't worked from your perspective in terms of getting patients into the office versus doing this over the telephone or over some telemedicine venue.
So I think, the key to that, I'll remind everyone, I'm primarily based in New Jersey. So we've been really hit hard by this epidemic, and we had to have a strong response that maximized not only effective treatment, but safety for our patients and safety for the clinicians. So we've really seen a strong shift in the delivery of our service. And as Dr. Stubblefield had mentioned, the kind of advent of telerehab services really taking off. So I think offering alternatives in terms of service delivery, but then also policies and procedures in place to help identify who potentially is safe, or I have clients where the benefit of coming in for hands-on therapy outweighs the risk that that patient may face by coming in. And I think really strong communication within the team, Dr. Stubblefield providing some of the medical guidance, having very close and candid conversations with our patients and their referring teams to identify who's most appropriate to come in, who's appropriate for telerehab services, and then working together with the rehab team to make sure that the telerehab services that we're providing are at par with the standard of care for what would be provided for that patient in the clinic.
Yeah, I think our experiences have been similar. I go back now and I think about 2 months ago in the head and neck cancer clinic, which is really a continuum of care clinic. We really believe that prehab and post-treatment rehabilitation should be integrated in the cancer treatment, and that's exactly how we run it down here in Houston. And but we had to quickly scramble and figure out what to do with our cancer patients. I'm thinking back now to March, to those dark days about 6 or 8 weeks ago, For me, the paradigm shifted a bit right around that time, where the hospital got ominously quiet. Here in Houston, we didn't see the struggles that they had in New York. Still haven't, by the way. But there was really a dark cloud kind of came over all of us, and we basically came to a grinding halt. And I can say this for a lot of the cancer programs in this region too, that we speak to in other areas beyond head and neck. But you know, the cancer patients kept calling the office, and we have a wide capture area. And so I remember telling my staff that I'll come back to the office next week, but I'll only see new cancer patients. Everything else needs to be on hold for a while we sort this out. And so there was a lot of trying to figure out how to do it safely. What do we need as providers to be safe? What do our patients need to be safe? And that's been a moving target. That has changed almost every week. But when I came back to the office after about 3 days of trying to figure this out on Zoom phone calls with my staff, there were 20 patients waiting. They were all new cancer patients. And I walked in the room with the first one, and I said, "Tell me what's in your mind. You're a 70-year-old man with a mass in your neck that's been biopsy proven." And he told me, "Well, I have this cancer now. You know, I might get COVID. COVID may kill me, but the cancer I have now is here now." And it really was an ethical turning point for me personally as a cancer physician, where I knew that we have to find a way to treat these patients. And I mean that not only in terms of the traditional pillars of chemotherapy and radiation and surgery, but also rehabilitation, which, you know, the paradigm has already shifted on this well before COVID. We know that cancer rehab is part of cancer treatment, and so is cancer prehab. And so all these things, I believe, are our ethical duty to find a way to access our patients safely, and to create these new roads for our patients to get rehabilitation. I'm thinking about some of the patients I saw in the last few weeks, and now that we have our office back and running and our telemedicine venues running as well, who just finished chemotherapy and radiation right as coronavirus fears struck in April or March. And they really didn't get access to what we consider world-class rehabilitation in those first few weeks. And they fell behind, and you could really see it. And so now we're actively trying to catch up with those patients and make sure they get, of course, the cardinal things for us are speech and language pathology and lymphedema therapy. We consider those to be the two pillars of cancer rehabilitation in the head and neck arena. So I want to move on to the next polling question here, which is, how are you treating your patients today? And so all of you in the audience, you'll have a chance to answer this question, and we'll see what you're saying here. How are you doing now? Are you not treating patients at all? Are you, have you found a way to perform telehealth? Are you seeing patients in clinic? Are you doing some combination thereof? So go ahead and click the screen, tell us your answers. And we'll give everyone a moment or two to file in their answers. Okay, good. I have the opportunity here to see the numbers as they come in, and I'll read them aloud to you. It looks like about 40% are doing some combination of in-clinic and telehealth. Another almost 40% are doing in-clinic alone. There are about 5% of you who are doing just telehealth, and then about 15% who are not treating patients at all right now. And I think that's important. That really helps us understand what's happening out there. A lot of the communications I've had in the last few weeks have been with folks like my peers on this phone call, but across the country, saying, "Hey, what are you doing? How are you figuring this out?" And some of it is really small and specific things like, how are you screening patients to figure out who's safe to come to clinic? How are you triaging patients to telehealth versus an inpatient visit? Let's go on to the next slide, please. So I want to turn this back over to Dr. Stubblefield and tell us more about kind of logistics in the clinic right now. What processes have you implemented to keep your staff safe, to keep everyone comfortable with it, and to, of course, deliver the care for the patients? What's working for you guys?
Yeah, well, thanks, Ron. So I'll speak about what I'm doing as a physiatrist in clinic, and then, we'll shift and talk about therapy. So, we've been, I think, very forward at Select Medical and Kessler about making sure every patient, every time, every staff member is screened, everybody wears a mask. When patients are coming into the clinic, they come straight from their car to the room. I do not want them doing any paperwork at the front desk where they're exposed to anybody. I will, come in then and I'm the only person who sees them. Of course, I'm wearing a mask and gloves and everything to keep the patient safe as possible. And of course, washing my hands until they're raw, as we all have been doing. And that's worked fairly well. I think, but even backing up from what we do practically, honestly, for me, the superpower of COVID-19 is not that it's incredibly infectious. It is. It's much more infectious than the flu. It's not that it's incredibly deadly. It is. The real superpower is asymptomatic transmission. The fact that somebody can be shedding the virus and infecting other people and not even know they have it. So that said, that is the thing that scares me most about this virus. So I try to keep my patients out of the clinic as much as possible until we know, at least here in New York, New Jersey area, where it's really been hit hard, until we know it's down below, a level where we think it's the risk of them coming in is fairly low. And we're starting to get there, I think. So that said, I am, as I mentioned before, I'm only seeing patients for injections, right? Or if I have to do something to make a diagnosis. When me seeing them in person is going to change their management and what I can do for them. Otherwise, most of my patients, when I'm just refilling pain meds or doing a check-in, can really be done pretty well virtually. And I've had one or two that I do need to come in to see me, right, to really kind of clarify the diagnosis. That said, I take the same approach to my therapy referrals. Again, we created a telerehab service almost immediately, and we've been very aggressive. We've had all hands on deck from our national team and our local team trying to really optimize what we're able to do. And of course, which patients come in is always the big question. So for me, at least initially, I've been sending everybody, with rare exception, to telehealth. And a head and neck cancer patient is kind of a classic example, because somebody coming in may have certainly physical therapy needs from their cervical dystonia. They will have lymphedema. They may have mild cognitive impairment. They may have trismus. They may have shoulder dysfunction. So they may literally need PT, OT, SLP, lymphedema, and cognitive as a treatment. And I will literally, and Tiffany can attest because she gets my referrals, send them in for all of the above and let the schedulers kind of sort out what we need. And my experience so far has been that we've been able, with a relatively sophisticated patient, and our therapists do pretty well with them.
Tiffany, give us more on this topic. How are you seeing it from your end?
Mm-hmm. So I think that it's a very fine balance in that triage system. So if there is an urgent or emergent need that would require that patient to come into the center, because we wouldn't be able to provide the same level of care if they didn't, then we'll have that patient come in. Meaning, let's say their edema is so bad that it's having difficulty breathing or difficulty further swallowing, or if they need to come in for an instrumental so that they can do a modified barium swallow study and get some results that will help guide treatment. And those things are only done, again, when the risk of coming in, is not outweighed by the benefit of coming in. With telerehab, as long as the patient is safe for telerehab and we know that we can effectively progress the patient towards their goals in their care plan, then we're using telerehab as a complement to therapy. And we're seeing a lot of success with that. And I think it's interesting because we see that from the point of view of patients who are established with us. But I think in the era of COVID, you've mentioned prehab, a few times, and prospective surveillance. And I think during this time, telerehab offers a really interesting perspective into our patients' lives that we weren't seeing before, and perhaps helping us to see more indications for telerehab. Seeing how a patient is functioning in their own home environment is very different than seeing how they function in a clinic. And being able to have that insight is unbelievably important and actually allows us to modify and tailor our care plans more so than we may have been able to do in pre-COVID days. It may allow us to involve family members or caregivers to do more caregiver instruction if those individuals weren't previously allowed to come into the clinic or able, transportation or time barriers. And I think we have a unique opportunity here for individuals who are now on stay-at-home orders that may be at risk for functional decline, and may be more at risk for more pronounced effects from their cancer or their treatment, to reach those people at a time of social isolation and maximize their outcomes and help get them through this time. So I think we're actually seeing a lot of really great indications for telerehab that we may have not realized otherwise.
Yeah, I'll share with you some. I love all of that, and I think it really speaks to some of the trends that I think will tell the story of coronavirus and cancer rehabilitation when we look back on this. Hopefully, as soon as this pandemic is over and as soon as possible. I think about three things when I listen to you, Tiffany, and Dr. Stubblefield talk. I think number one about the specific risks in regards to oral and head and neck cancer patients, because we're in the mouth so often, and we know that the mouth and the nose is the reservoir of the virus. And so even when patients do come to the office, as Dr. Stubblefield had indicated previously, it's such a high touch scenario, with gloves on, with a face mask, with covering of the eyes, with an eye shield. We're still so close to the patients. And I didn't think about that much until the last 2 months of my career, and realized that as much PPE as we can wear, but to really do a comprehensive head and neck examination requires us to step across that threshold, and to assume some risk, and that's been one of the challenges in this. Whether you're a speech and language pathologist or a physiatrist or any of the specialties involved with the care, what we don't really quite know is how are head and neck cancer patients within the coronavirus doing. We don't know if they have a higher risk of contracting this disease, assuming that they're during an immunocompromised state because of their chemotherapy or other treatment. We don't know how the oral mucosa responds to coronavirus after it's been radiated. There's certainly some anecdotes of whether head and neck cancer patients are more or less susceptible to this coronavirus because their mucosa and the lining is so different. And this is something that our patients are asking us all the time in the office. And we don't have the answers. I think we'll learn this as we go. Like Dr. Stubblefield had mentioned, we'll build the plane as we fly it. I see a second trend here as well, which is that there's been a generalized trend in medicine, out of the OR into the clinic, out of the clinic and into a lower cost venue. And certainly the idea of telemedicine extends the reach of rehabilitation, meaning, we know that there are many barriers to getting cancer patients rehabilitation. A lot of them have to do with education. It's not just the patients that need the education. Sometimes it's the primary providers. It's the cancer doctors who don't quite understand the value of an occupational therapy visit, for instance. And sometimes patients don't have the ability to pay the copay. They don't have a ride. There's so many barriers to getting a patient in front of somebody like Tiffany on this line. And so here we have telehealth, where you really just need to have a smartphone and somebody like Tiffany on the other end, and you could access that care. And so maybe I hesitate to say silver lining, because there really are no silver linings to this pandemic, but maybe one of the opportunities coming out of this will be to permanently extend cancer rehab using some of these newfound technologies like telehealth in particular. But this at-home trend, this trend to treat at home, is not just a telehealth thing. I think also about our friends at Tactile and what they've been doing for a long time, which is really delivering garments and more specifically compression devices for patients at home, which makes it easy for patients to get lymphedema therapy actually done, where MLD is hard to get done and the compliance is low. I think about how patients who have these devices at home can stay in the safety of their home, where they don't have to have necessarily MLD drive all the way in and do that. It's not a substitute for MLD in any measure, but it's I think a good complementary modality of treatment for them. But coming back to the telemedicine topic, and specifically for the PT and SLP and OT and the lymphedema therapist, Tiffany, give us what you know about the compliance issues right now, getting patients over and making it compliant and safe to perform telemedicine. I know you have a few slides lined up for us, but I want to broach that topic because I know that's on the minds of a lot of people. Are you able to do that in your environment? Are you able to do that and get reimbursed for it? What are the compliance issues, the documentation issues, and so forth? What are you seeing?
Mm-hmm. So, it's an interesting question, and it's an interesting time right now. I kind of refer to it as we are living in the era of executive order. So even though there was some, dabbling in telerehab, there were a lot of barriers in place prior to the COVID pandemic that were really not allowing a lot of rehab providers to provide telerehab. So reimbursement was certainly an issue prior to COVID, and there still remain some barriers there in terms of regulations and scope of practice and practice acts. It varied by state who was able to provide these services, and honestly, that continues to evolve on a state by state level. Here in New Jersey, fortunately, pretty early on by executive order, rehab professionals, our privileges were expanded so that we could provide telerehab. A lot of the private payers early on were allowing these benefits for their patients, but we really had to be extremely familiar with state practice acts. State practice acts, as they related to all different disciplines of therapy, PT, OT, speech, and then put in place strict compliance measures to make sure we were following all of the necessary guidelines, consenting your patient, making sure that, you are verifying their location, getting the address of where they physically are sitting so that you can make sure that you're in accordance with your state regulations, but also if, God forbid, your patient had an emergency, you would know where to tell EMS to go, since you're on a computer screen and then instead of, with that patient. One of the things that has been really helpful for us is even prior to COVID, there are established key principles for effective delivery of telerehabilitation. And these really are kind of based on four tenets that kind of overlap really, but they're different domains. So you see here, administrative, clinical, ethical, and technical considerations that will kind of guide best practices. So by administrative, that's where we're talking about things like our state practice acts, or, what policies, what patients and what radius they're allowed to travel from for virtual services. Ethical, making sure that we are providing the right treatment to the right patient at the right time by the right medium. So again, if I can't reach meaningful progress towards my goals, or if I wouldn't at least be delivering the standard of care by telerehab as I would in the clinic, then I really need to consider, is that the right thing for that patient? Technical considerations, what we're talking about here is what's the right platform? Do we have the right bandwidth and the right internet? And are we using a platform that allows us to file share or screen share so that we can make those sessions most effective? And then last but not least, clinical considerations. So there are qualities outlined that really demonstrate who the most appropriate patients are. The key considerations are they safe and will this be effective? Who the most appropriate clinicians are. Do they have strong clinical judgment and clinical decision-making skills? Because it requires modification to the evaluation and treatment techniques that we're used to providing in clinic, and making sure that all of those things kind of come together to provide an optimal patient experience that drives outcomes.
Thanks, Tiffany. Tiffany, I want to take us on to that next slide. I want to thank you for putting these next few slides together on this. Take us a little bit about kind of the evidence altogether, not specific just to head and neck cancer, but just in general regarding current evidence. This is, of course, all of this is pre-COVID, but it's evidence around what telerehabilitation can achieve. Tell us a little bit about this.
Yes, so what you're seeing here are some just brief summaries of two key articles published this year and last year by Andrea Chaville and colleagues. The first study, the effect of collaborative telerehabilitation. So collaborative meaning care provided by physical therapists remotely, but then also for impairment-driven rehab by in-clinic visits. So it was a collaborative care model, and the impact of that collaborative care model and telerehab on functional impairment and pain in patients with advanced stage cancer. So this was a pretty rigorous trial. It was an RCT, and what they found is when they provided this telerehab intervention in individuals with advanced stage cancer, they had really meaningful outcomes and improved function, decreased pain. Individuals who were admitted to the hospital had decreased length of stay, and that was on average by 4 days, which is pretty significant. And if individuals were admitted to the hospital, they were more likely to return home as opposed to have requirements for post-acute care. So in the days of value-based care that we're living in right now, we can see that this intervention was not only safe and feasible, but drove really meaningful outcomes both for the patient and from other stakeholders like payers. So this was really one of the key trials. Building upon that, there was a subsequent study that looked at cost effectiveness for this collaborative care model, and what they found was that it was extremely cost effective. So there were cost savings associated in terms of hospital costs and then post-acute care after, for individuals who participated in this trial and got the telerehab intervention versus just symptom monitoring.
Michael, I'm wondering if you have something to add on this, because you're involved in so much advocacy on this topic. This really speaks to the theme we all of us on this phone call are aware of, which is how important rehabilitation is. I see key metrics here, really quality metrics, things like hospital length of stay and cost effectiveness. It's obvious that patients who have access to this are going to bring down their total cost of care. What are your thoughts on this?
Yeah, no, that's great, Ron. So, the dirty little secret of advocacy is function and quality of life doesn't mean a whole lot to CMS, right? The Center for Medicare Services will just kind of look at you and nod politely and then go do something else. To really move the needle on any initiative to help patients, that's not enough. You really have to hit some of their key metrics. You need to save money. And doing that means keeping patients out of the emergency room, keeping them out of the hospital, nowadays keeping them off pain medications, particularly opioids with the whole opioid crisis going on, which also is another way of saving money. And if you can do that, then you might be able to actually move the needle and get regulations passed and get money to fund new things. So CMS has been very slow to the table with telerehab. Tiffany can talk more about it. She's buried in this. But they've just recently liberalized for us to be able to get reimbursement even in our provider base associated with the hospital therapy centers, but our private therapy centers or therapy centers not associated with the hospital or too far away from the hospital can't get that. So I'm hopeful, again, you said this is, to paraphrase, the only good thing to come out of COVID, right? This is a change that I think will stand to help a lot of people, although the cost obviously is very high. And I think that benefit is going to be that we are going to be able to provide these services to underserved patients, to patients who can't come into the center, patients who can't afford a copay or afford the gas to get where they're going. And by doing that, we are going to be able to keep those patients out of the hospital. We can't afford the cab to get to the rehab center, but the ambulance will come and pick them up when there's no other option, right? And this is really what we're trying to save here. And I think, there's tremendous promise for telehealth, which is why we're 100% in on trying to do it right. And as Tiffany said so eloquently, the right patient for the right service at the right time.
Yeah, I share your sentiment on this. I think we're at a critical time point where it really ought to be mandatory, or it could really serve as a quality metric on head and neck cancer care if patients are getting comprehensive rehabilitation services. Meaning, and I've said this many times before to other audiences, if you were to measure a good head and neck cancer program, it wouldn't be the chemotherapy, the radiation, or the surgery per se. It would really be what percent of their patients who are getting comprehensive treatment are also getting comprehensive rehabilitation, and are they getting it in a timely fashion? And I think that's probably the most important metric in a good cancer program, and definitely one in the head and neck arena. There's no question about it. And I think you're right. I think the timing is interesting because this coronavirus will force us to figure out telemedicine. It's forcing everyone to, and all specialties of medicine. It may force the insurance companies to allow us to perform telemedicine. It may force them to allow our partners in the rehabilitation services to as well. And that might actually finally break through and make it a standard, an NCCN standard, but also really a standard of care, that patients get access to these services and rehabilitation providers as part of the continuum of their cancer care. Tiffany, I want to turn back to you on the evidence specific to head and neck cancer care. And I know this is heavy on speech and language pathology. I'm happy that it is, because speech and language pathology is really one of the pillars of head and neck cancer rehabilitation. Tell us what we need to know in your survey of the literature.
Sure. So again, brief overview. In a recent survey, your summary of the literature surrounding telerehabilitation for individuals affected by head and neck cancer, specifically those provided by speech language pathologists. Again, we see the same themes, that this is safe and effective. We see that there is good access to care. This helps to fill a gap that we all know exists in access to care for all the reasons that Dr. Carney just mentioned. Enhanced outcomes, meaning outcomes that are meaningful to the patient and at least comparable to those achieved in clinic, and in some cases even better. And then optimal health service efficiency. And if you kind of look at two key studies after that, we see a randomized control trial. This was conducted in Australia in a public healthcare system, it's worth noting, but of a multi-site speech pathology telepractice service providing swallowing communication interventions. So somewhat complex interventions via telepractice. And in these studies, what they found is that when patients were treated by an expert speech language pathologist at kind of what they called their hub sites, they saw improved service efficiency. So there were fewer number of events and shorter episodes of care. So it was more efficient overall. And the satisfaction that the patients and the clinicians delivering the rehab reported were higher, which is really interesting. Building upon that, similar to what we saw in the Cheville study, they then looked at a cost analysis and found that the cost was less when they delivered this synchronous, meaning face-to-face telepractice service for individuals with head and neck cancer, and those cost efficiencies were over the standard of care. A couple things I think are worth pointing out here. Dr. Carney talked about access. And I think one of the interesting things that COVID has done is kind of thrust a spotlight or given us a new understanding or appreciation for the access for some of our general medical conditions that we've always had, right? If I get sick, I go to the doctor, they help me, I get better, and we're good. But with COVID, more people have experienced, I can't go to my doctor, I can't get a test, what is my treatment? And I think it kind of thrusts a spotlight onto, well, NCCN guidelines do call out speech therapy for individuals with head and neck cancer. They have for a little while, but we haven't had that access, but people don't quite grasp that. Right now, I think we're in the time where we can really advocate and say, hey, that access is necessary and we need to provide it, and we need to demonstrate outcomes similar to this and provide evidence-based telerehab practice so that when COVID ends, we have a sustainable service to fill that gap in access and drive outcomes for our patients.
Yeah, I think you're right. I think there's no question that when it comes to a lot of the speech and language pathology for head and neck cancer patients, aspiration evaluations, but also swallow exercises. We had onesies and twosies, people reporting a few here and a few there, or a series here and there. But I suspect in a year or two from now, we'll be able to look back on a much broader experience now that we're all talking about telemedicine for speech and language pathologists, which is really so important. Let's move on to lymphedema specifically, a topic that is, in my opinion, kind of the sometimes misunderstood and sometimes forgotten other pillar of head and neck cancer rehabilitation. In our practice, we really consider everybody who's had radiation somebody who needs to be considered for lymphedema. There are, of course, many other risk factors. If you've had surgery and radiation, we consider that much higher. And we have a large focus of our research is really on the internal lymphedema, where we suspect patients need the most attention, but also have the most opportunity for improvement. Our work and our research team has really shown that there's a population of patients who do outstanding speech therapy, and they're best in class in terms of doing speech and language pathology and doing all the rehab that we prescribe for them, but they don't get better until we really sit down and address lymphedema. And I think the opportunity for lymphedema in head and neck cancer patients is huge, and we're just starting to discover it. Dr. Stubblefield, what are your experiences now in terms of specific to head and neck cancer lymphedema, and also to radiation fibrosis syndrome, which you've coined the phrase and you've written the papers on. I've read those papers. I think those papers need to be in marquee. We need to be talking more about that. But tell us a little bit about both lymphedema and radiation fibrosis syndrome vis-a-vis COVID. What are you seeing for the future for this?
Yeah, this is, so every time I have clinic, I'll have 2 or 3 new radiation late effect patients coming from all over the country. Again, few good things of COVID is I can virtually see patients from anywhere without them having to come in and get reasonable accuracy in my assessment. So I agree with what you said, Ron. My take on any head and neck cancer patient who's had radiation is that they have lymphedema until proven otherwise, and nobody's ever been able to convince me otherwise. So I just take that at face value. Those patients also come with all the issues I mentioned before. They come with dysphagia and dysarthria and trismus and cervical dystonia and shoulder dysfunction and baroreflex failure and a variety of other things that, I'm in the business of trying to follow them for and optimize. I look at lymphedema and radiation fibrosis as very intimately related. So radiation fibrosis is that slow, insidious, fibrotic process that occurs in response to radiation. It's immortal, meaning that it never stops. It goes on forever. We don't fully understand the cascade that is causing it. There seems to be at a minimum some low-grade inflammation, some endothelial cell dysfunction, and some other what I call evil humor mediated processes going on. Lymphedema is also a slow, insidious, fibrotic process that has a lot of inflammation associated with it. So I look at getting the lymphedema out of my head and neck cancer patients as well as possible as being paramount to trying to impact their other issues. I think there is some data for dysphagia, but I look at dysarthria and the cervical dystonia in the shoulder, and everything is related anecdotally, even though we don't have good data for that. That has been my experience, that treating the lymphedema absolutely has to be a component of comprehensive care of these patients. I also, and again, this will never be proven, right? And so this is a Stubblefieldism, forgive me. But radiation fibrosis, I call the gift that keeps on giving. It goes on forever. We don't have any way to impact the actual underlying mechanism. But I've often wondered if getting rid of the lymphedema would in any way slow the progression. And designing a study to do that will be very challenging, something that we may do, and I think the FlexiTouch device is making possible to do. But I think just because these patients are so impaired, and again, risk-benefit, very low risk to treat the lymphedema with potentially huge benefit if you're keeping them from getting a PEG even another few months longer, or keeping them from having any of the other issues that I talked about. So I look at these as married processes that need to be considered anytime you're taking care of a head and neck cancer patient with radiation late effects.
Yeah, I would refer the audience, those of you interested to learn more. Dr. Stubblefield is really has described the phenomenon that we all see every day in our head and neck cancer patients. Some of these terms like the cervical dystonia and radiation fibrosis syndrome, which is exactly that. It's a syndrome. It's a cascade of things that you can almost predict, and that we see all day long in head and neck cancer survivors. But I also share a concern that the best thing we can do for radiation fibrosis syndrome is prevent it, and it could very well be that timely treatment of lymphedema can play a big role in that. And that's hard to prove, but it seems quite obvious when I sit in my clinic sometimes and I'll see two patients who were treated for the same cancer around the same time, with the same equipment and technology by the same doctor or similar doctors. And one of them, their neck is fused, their larynx is immobile and frozen, they have dysphagia, they have chronic pain, they have shoulder drop, they have musculoskeletal sequelae. And then you see the next patient come in and their neck is supple, and their range of motion is good and their swallow is intact. And often what arbitrates that difference, if you start to ask forensic questions, I'm talking about 10-year survivors now, is really how active they were. Was this a 40-year-old who went back to chasing his or her kids in the backyard and was busy at work, or was this somebody who, because of their impairments, really stopped moving? They kind of ground to a halt. And I think of physical activity as very important for cancer patients, especially from the chest up, regaining a lot of that muscle tone. But I think that is actually poor man's lymphedema treatment. Exercise is a proxy for lymphedema therapy. So are swallow exercises. It's a kind of like an internal lymphedema pump, if you will. But we have better and more sophisticated tools, technologies, and education for that. And of course, the lymphedema therapists on the line, you guys are our best advocates for the importance of lymphedema therapy for head and neck cancer patients, especially as we mentioned, as we start to advocate for a bigger role in this in the continuum of care for head and neck cancer patients. So next slide, please. We want to ask our audience, and we have about 12 minutes left. So I want to bring this polling question to bear, and then I want to open up the questions to the audience and make sure we hear your voices as well. But tell us what you're doing now for lymphedema. We're interested. Are you using compression garments? Are you teaching self-MLD? Are you using pneumatic compression, exercise? Are you integrating swallow exercising and elevated sleeping to try to improve lymphedema in your patients? We'll look for those answers.
And I think they can select more than one, right?
Oh yes, that's right. On this one, you can select more than one. Thank you, Dr. Stubblefield. Yes, and actually, I think most of you have selected more than one. In fact, the numbers are all 80% or higher here for the first four. So 80% or higher are choosing one of those first four options. Less of you are choosing the sleeping elevated, but it seems like everyone seems to agree that all of those treatment options are good treatment options. Let's go on to the next slide here. I think we've spoken a little bit already about the short-term and long-term impacts of the coronavirus for our head and neck cancer patients. We've spoken about the economic impacts and some potential new opportunities, especially vis-a-vis telemedicine. I want to now open it up for the Q&A session. So let's see here if we can get some questions. I'm going to turn it back to Sarah, who is going to ask us some questions from the audience. Sarah, tell us how our audience can ask questions of us so they know how to do it on their screens.
Yeah, absolutely. So at the bottom of your screen, there is a Q&A icon that you can click and submit your questions there, and we will get to as many as we can. We've had some questions come in throughout. I'm just going to read a few of those. So one question that came in is, with regard to patients who may have additional cognitive challenges and family need to be trained, and they've been deemed, quote unquote, not appropriate for telehealth visits, therefore need to come into the clinic, are you allowing family and caregivers to come in with patients for instruction?
Michael, do you want to take that one?
Yeah, no, that's a good question. The biggest analogy I have to that so far is our inpatient hospitals, where we've been just discussing, because COVID is running rampant, starting to have some situations where we can allow family in. On the outpatient side, I don't know, to my knowledge, Tiffany may know if it's come up, but I can tell you how I would answer that when I get that question from one of my own therapists. Again, it's a risk-benefit analysis, right? We have to all be convinced that the benefits of them coming in are very high relative to the risk of infection. It also has to do with how your own personal community is doing. If you're in a place with very low COVID, your risk is much lower. If you're in Manhattan, your risk is very much higher. And I would let them come in under those circumstances. But if, one of our hospitals, we shut down therapy, right? A couple of them because of, the risk being so high and the fact that there was so much COVID out. That those have since opened up and everything's better. But there are potentially some places in the country where you may have outbreaks, in which case I would be very loath to do that. Other places, like, apparently Texas is doing reasonably well in some areas, I would be fine with it.
Yeah,
Tiffany, do you have any?
Yeah, Tiffany, what do you think?
I do think it depends on geography. I've heard different things in different places. I can tell you that from most of the therapists I know in our area, unfortunately, unless there is a significant risk, the patient, generally no caregivers or others are not allowed to come in for therapy, but that also doesn't mean that you can't involve or include those in that person's care plan. That's another great indication for telerehab. I've also seen people get very creative and crafty with this. Of course, making sure you're completely compliant with HIPAA, but perhaps treating a patient in front of a window, and you're here and you literally have a physical barrier and the family member can see and they can call in. I think that was one of the most creative strategies I've heard of. But we're therapists, and especially lymphedema therapists, occupational therapists, you are extremely creative people. So how can we get around that to provide the services our patient needs?
Yeah, I think, today we had our Thursdays are always our head and neck cancer survivorship clinic. And it really felt almost back to normal today, but there were some differences in our clinic. And we do try to limit just the patient into the office. We don't even want the person who drove them to come with them. But we have had some of these patients as the cognitively impaired, the one in a wheelchair, the one who needs help, the one who's having difficulty with communication, the trach and so forth. And in those situations, we've had to make exceptions to let more than one person into the room, not just the patient alone. But we've also, I like Tiffany's comment, we more and more rely on the patient sometimes to say, hey, look, can I open my phone and get some of my family members on this call? And I have to admit or concede that years ago that seemed a bit odd to me, but it doesn't seem odd anymore that I'm going to get my wife on the phone here and put it on speaker so she can participate in this conversation. In fact, I encourage it, and especially for when it comes to things like talking about cancer treatment and rehabilitation. Sarah, give us another question.
Yeah, we have a few more. So this comes from a clinician who said they were struggling today with how to best do MLD on a head and neck patient. They both had masks on. The therapist was wearing goggles and gloves, stood behind the patient during the treatment, and her mask was falling off frequently. Any suggestions on how you're managing this, Tiffany?
I'm actually Dr. Stubblefield has been very intimately involved in development of our procedures for that. So I think he actually has some really great suggestions that he can share, and then I'll build on that. Absolutely.
I'm glad you have such faith on me. That's really a very challenging thing to do. Most of the guidelines that we have been making, like for speech language pathology, is really, when can you take a mask off? And the answer to that really is you can't. For these patients, the risk is way too high now. Just giving you some data, right? And I'm kind of skirting your answer, Tiffany, and letting you come back to you just to kind of outline the risk. So originally the CDC was saying people don't have to wear masks. Then there was a study, I think, on SARS showing that masks did actually decrease transmission by a significant percentage. I'm going to say 70, but I don't actually know. I've gone back and looked at all the literature on influenza, for instance, and masks in nurses wearing either an N95 or a regular mask, there's actually no difference, which was a surprise to me. And there's another meta-analysis showing that. And what was interesting there was that the risk of contracting influenza with either an N95 or a regular surgical mask was, I think, 21 and 23% respectively. So meaning that people were still getting it even with the mask and presumably all of the other safeguards. So that said, I really think that you're just going to have to work around the mask to the best of your ability and make sure that the patient's face and nose, because you are taking a risk, particularly if it's high in your community. And I'm back to that asymptomatic spread, which again, to me is the most terrifying thing about this virus and the reason that it's run rampant. If everybody had a big sign on their head that said, hey, I have coronavirus, then we wouldn't have this problem, but you don't. 25 to 50% of people can be symptomatic or be asymptomatic, but still be shedding the virus. Now, Tiffany, whatever those great ideas I had before, can you remind me?
Yeah, so, one of the things that I missed in the question, was there a face shield in the situation for the therapist, perhaps?
It wasn't mentioned in the question, but actually after the question was asked, another person chimed into the Q&A suggesting a face shield as well.
So, because that, there were a couple things that I heard there. I'd have a question about what type of mask the therapist was. I couldn't agree with Dr. Stubblefield more in that, although not ideal, you do need to work around the mask on the patient. I would also try and incorporate it. It's another great reason, we're trying to help our patients become effective self-monitors and self-managers of a chronic condition. So, really kind of pushing the norm. How much do I really need to be doing? And can I maybe start that education and have that patient do some things themselves, right? To reduce touch, but then also standing behind the patient. I heard the mask was falling down quite a bit. So looking at the type of mask and if you can perhaps get a better mask fit, I think would probably be very helpful there. But a face shield would certainly help. And the concern that I heard was the mask was falling off, which means that now we're going from touching the patient with a gloved hand to touching a mask to pull it up, which obviously increases risk. Yeah. So at very least, one of the clear things I thought about was a face shield in that situation, patient involvement in their care, and at least that face shield will help, and a better fitting mask seems like the best solutions.
And I would throw in the obvious, that as we're being sponsored by FlexiTouch tonight, that might be a role to use a device in a patient like this while teaching them self-MLD for the problem spots that you can't give. And I think in a competent patient, a really sophisticated patient, a good learner, I think you can almost do this potentially virtually and get away with it. Couldn't agree more. The face shield goes without saying, but thanks for saying it. But yeah, it's a very high risk situation. I can't even overemphasize that enough. That just taking off the mask and treating them and shrugging your shoulders and saying, oh, well, we're just going to get it done and feeling like you're being a hero is not the way to go in this situation.
So along those lines, we do have some questions around, how are you when you are operating via telehealth, telerehab, performing circumferential measurements and MLD education when you're not with the patient?
Yes. So it is challenging. And what I've done in this situation is I do feel very fortunate to be involved in a lot of networks, both within my own professional organization and within my own work environment. So there has been a lot of creativity around this. If you're using different types of forums, number one, I know you're specifically asking about circumferential measures. But I think first and foremost, listening to our patient and incorporation of patient-reported outcomes is extremely important here, because even in patients with subclinical lymphedema, what they're feeling and how that's impacting their function can tell us a lot and can help with some objective goals. So that's number one. Number two is being creative. So I know for head and neck, some of our therapists have included caregivers and instructed them on literally how to take some of the measures. I do know that some individuals have started a session and said, this is what we're going to do on the next session, sent helpers or assistants instructions on what they're going to be doing, the necessary supplies needed, and said, can you have this available? Great, on Tuesday at 2 p.m. I'm going to walk you through this. And they've been able to really get the assistance of friends, family, or other supports for the patient. And I think that's extremely important. Also kind of thinking about the ability of whatever platform you're using to kind of photo document. So thinking about how you can standardize your patient's environment in their own home. And if you have a photo capture and the consent of your patient to do so, then standardized photo captures where then you can measure there. As far as circumferential measures, we also had a therapist that got really creative and said, okay, I'm going to use, we can't use a ruler, and a measuring tape isn't going to work here. So they literally measured out, had yarn, so it couldn't be stretched too much, but wouldn't be too taut again, and said, I need you to go from this point to this point. Now place it against a ruler. Okay, give me that measure. So it's time consuming, but I have seen it done, and I've seen it done well. As far as instruction and self-MLD, I think the key here is really very clear in your communication, and also having the support material and a platform that allows you to use those resources. So pictures, or allowing to screen share to show a video of how that's performed, also involving a friend, family member, or support to help perform that if need be, and then file sharing those documents with the explicit instructions to the patient seems to be some of the best ways we've been able to teach that, and we're getting good results with it.
One of the questions.
And I just
go ahead.
I just wanted to fill in too what Tiffany was saying. As we are trying to perfect our telerehab services, we're talking about finding creative ways to get the tools of the trade to the patients, right? They shouldn't have to be using yarn when they can have a dollar tape measure sent out to them, to be able to do it properly. So, and there may be other devices, TheraBands and that sort of thing that we need to send to the patient. So that's something we are actively working on that I think other people will find useful as you try to create your own telerehab program.
I would also chime in, if I may, Sarah, and just, I think one of the things that's emerging in general about lymphedema is that external measurements can be important, but they're at best, in my contention, a proxy for what's going internally, which is really what's driving a lot of the symptoms and the quality of life deterioration. And so, I hesitate to put too much stock in measurements. I think if you can't take measurements because of coronavirus, but that they have lymphedema, and all the folks on this phone call are already, they know how to know who has lymphedema. I think that the burden is to proceed to treat. I think it makes sense. We ought not let something like that, stop us from getting a patient the education, the MLD, the comprehensive decongestive therapy, the FlexiTouch device, or treatment. Sarah, we probably have time for maybe one or two more questions here. We've passed our mark, and I want to be respectful of everyone's time, but maybe we have one more question. Sarah, what do you think? Yeah,
so I can kind of group a few questions together that came in. So a grouping of questions is, how are you dealing with, a lot of therapists have been furloughed, and so limited access to care for patients. And then sort of grouped with that is there a place for home care to be utilized to help these patients? Kind of a few questions along those lines. So what are the thoughts from this group?
I can kind of speak to that a little bit. I do know a number of people, again, through my professional organizations, and that furloughing is, a real issue right now. And so again, we're seeing that decrease in access to hands-on care. The question sort of becomes, what can you do to supplement that, right? So, really educating a patient as to why they need specialized services and why they may need to go a little bit further to get those right now, if it is safe and appropriate for them to go into a center. I can also say that as we've built out telerehab within the Revital program, there's been a lot of thought given to making sure that we can provide those comprehensive cancer rehab services virtually. So now it's actually been kind of interesting. We can connect people a little bit more with a lymphedema therapist virtually, or a cognitive rehab therapist virtually, or more patients now perhaps more than ever that are able to get specialized cancer physiatry services. It definitely hurts, and I hope that, the healthcare workers are needed now more than ever. So we hope to get everyone back soon. But I think, again, that telerehab service, or instilling the value of those services in the patient to make sure they get into the right hands, even if it's a little less convenient right now is kind of important there.
Thank you so much. We do have some additional questions in queue, and I just want to let the attendees know that if you submitted a question and it was not answered this evening, we will do our best to follow up with you with answers from the panelists after the fact, and we'll send that to you. And if you did not submit anonymously, obviously we can't get those to you, but just a sincere thank you to our panelists, Tiffany, Dr. Stubblefield, Dr. Carney, for being here tonight, and to our attendees for taking the time to learn more about how we're caring for these head and neck patients who need so much help, regardless of whether there is a global pandemic happening or not. So I appreciate it, and thank you for being here.
Thank you, Sarah. And I want to also just chime in and say that all three of us, Dr. Stubblefield, Tiffany Kendig, and myself, are happy to be reached as well. So if you submitted a question, our friends at Tactile know how to reach us, and we are always open for collaboration and communication for our patients' care. I know that the group on the line today, I could feel it over the internet, are all great advocates for our patients who are the constituents. And I think this last question about furloughing really speaks to the matter at heart. We've taken a big hit for our cancer patients, and cancer rehab has as well. But I hope the message this evening is one of hope, that we will emerge even stronger with more and better tools to reach more patients. That is really the call to action tonight. And you've heard it from my friends here on the panel. And so I wish you all a safe evening, and hope to see you all soon in person in a new world without coronavirus. Have a good evening, and thank you, Dr. Stubblefield, and thank you, Tiffany.
Thank you. Thanks, everybody.
Everyone.